Okay, so what we're going to look at here is doing some ultrasound to the lateral abdominal wall and also going across to the rectus abdominus and also the linea alba complex and the opposite rectus abdominis. So what we've done first here looks a little bit messy, so I've kind of put the gel on it initially. So I think it's good to emphasize that you're trying to have a good bit of gel on, because unless you've got loads of gel, you won't get an image. You'll get what's called streaking. So you'll start to get loads of kind of black lines down through the scan. So it's good to have the model or patient in a position that's nice bit lower than you, so you can hold that probe with a very relaxed hand, preferably slightly flexed elbow, relaxed shoulders, so that you're in a good ergonomic position. Because when you start to do a lot of this, you can be doing it for quite some time. We're going to start doing some scanning in lying, and then we'll progress also to doing some scanning in standing. Okay, so a couple of things to notice though is kind of trying to visualize, well, what are we actually going to look at here on the screen? It's kind of back from our anatomy, which is, as physiotherapists, always quite exceptional. So we're looking at initially skin, superficial fascia, which is really made up, especially in that abdominal cavity, adipose tissue. Then we've got the deep fascia, which is that kind of stocking-like structure that wraps around those superficial muscles. And then that deep fascia also gives off those intramuscular septins or septi. As we're out laterally, we would have the external oblique muscle. We would then have the bigger internal oblique. And then finally the transversus abdominis. So when we visualize a scan, we really should be able to see those three muscles clearly. If we were to just do some just anatomical detail on the model, as we go medially, we're getting towards the rectus abdominis, and those three lateral muscles help contribute to that rectus sheath. Kind of invests the rectus abdominis. And we know that that differs where along the kind of vertical length of the rectus abdominis we are. Kind of above that arcuate line, the internal oblique tends to divide going anterior and posterior, whereas below the arcuate line there tends to be more of an anterior support of the rectus abdominis and linea alba. And that's thought to be one reason why the linea alba, or that kind of midline structure, has got a shorter distance inferior to the umbilicus. And I think no matter where you're scanning, whether you're scanning laterally, rectus abdominis, midline, it's trying to visualize, or what should these tissues look like underneath. We also want to know, well, where is the marker? So the marker is on this side. So ideally, this is going to match where on the screen the marker as well. So I'm going to scan the model's right abdominal wall. So I'm going to have the marker on the outside, so it's lateral. And when I look up at the screen, that M, which signifies the marker, should also be on the lateral aspect. The reason for that is I want that screen and the tissues in that screen moving in the same direction as myself. So as I look at the model's abdomen, say like that section, whatever is lateral in the abdomen, it's really important that that's lateral on the screen. If I move the probe medially, I would expect, as I get medially, to arrive at that big rectus abdominus. And I'd expect some of these lateral muscles to start to disappear. And we'll talk about what these are in a minute. So I'm going laterally. I see that top muscle starting to disappear. I see the lower one start to disappear. And the middle one's continuing on into that rectus abdominis. So it's important to really check, well, where is the marker? And as you look at the structure you're scanning, does it match what you've seen on the screen? Just give you an idea of what happens when that doesn't match. So I've just turned the probe around now, so the marker is on the medial aspect. So as I go, I'm going medially on the abdomen. The screen is going laterally. So that's confusing for me to see. So what we're going to do now is just talk through some of the parameters. So what I'll do is just get the model here just to hold the probe. You can just hold it down like that. Okay, so that's quite a nice image there. So what are we seeing here? So we're seeing three things. We're seeing 3 layers of muscle in the lateral abdominal wall. But I'm going to see really from playing around with some of the parameters, can we get those clearer? So we're going to come down to the machine here. So probably what I want to do first of all is adjust the depth. So I'll find the depth button, which is over here. And I'm going to turn this and we'll see what happens. So this, as we go deeper, the screen is narrowing. So that's probably a little bit too deep. It's probably a little bit better. We want the structures we're looking at, which in this case is the 3 layers of abdominals, really forming about 2/3 of that screen. Next, I'm going to look at the gain. So the gain, as we've talked about, is this, or the eye touch is this button here. So if we go one direction, we go a lot whiter. We want it a bit darker. So I would be happy with that image there. A little bit too bright. That's good for me. We can also look at the TGC, which is also to do with the gain. But generally, you move these very subtly, and this just affects the gain at different depths of the image. So I'll do this to the extreme. Too black, better. Too dark, too white, bit better. So you only need to move the TGC very subtly. So what other parameters could we use to get this image more clear? Although this is a good image. This is the area of the machine that tends to cause some people a little bit of distress. But I now look on this as a way of really refining the image, getting it a lot better. So I look on using these as really helping me to get a better image. There was a time when I used to try and, almost work out what the best combination of these was. And that in itself is not a good way to scan, because the scan moves away from actually what you're seeing on the screen, interacting with the patient, to trying to work out the best kind of algorithm to use. So what I do now is I go to frequency first, and as I'm looking at the image, I'm going to change the frequency, and we will do that by using the set button. So I'll show you what happens when I change set. So it goes from 10 to 8 to 10 to 5. And then I'm going to see, well, what effect is that having on the image? So we're now in 7.5, 8.5. That's definitely a bit worse. Not great. Probably the best one there. We talked in some of the other videos about the dynamic range. I'm going to do that next. Same again, I'm going to flick through this and see what effect it has. That's a bit too bright. That's probably better. Then I'm going to go back up to the I-beam. Just see if I change this, does it help? Not really. Eye clear. Worse. Better. So I would work down through these. We've already talked about the left-right flip, so that would change the position of the image. We might do that if we're going to the other side, but not something you have to really worry about. And then the up-down flip is really when we come to do probably the pelvic floor scanning using a curvilinear probe. So I'm just going to take hold of the cursor, the probe again. So what we're seeing here quite nicely, that's streaking, just losing a bit, get a bit more gel. So when we put an ultrasound probe, very light pressure lateral abdominal wall, and we're really trying to see these 3 layers of muscle. So first of all, we've got skin, superficial fascia. Then we've got the deep fascia, which is that very thick white line. Then we've got the external oblique. The middle one, thicker one, is the internal oblique. And then we've got the transversus abdominus. And we can really confirm that that's what those are. I'm going to get the model just to draw the tummy in. And let go. And again. And let go. And those should, when they contract the muscle, they will widen. Just draw in again. And let go. It's going to look at really where we end up medially. So I'm moving the probe medially. Now the reason we're losing this a bit is because we need more gel on. We'll just do that. And as we go medially, internal oblique continues. Start to lose that external oblique. It's kind of being blended in. We can see the point where it's blended in with internal oblique. And transversus abdominis will also start to disappear. And then we're getting to this really nice, thick, fleshy muscle, which is the rectus abdominis, in this case the right rectus abdominis. These are very clearly defined fascial lines. You know, that looks like a very straight white line that's really wrapping around that very kind of plumped, well-developed muscle. And the reason these fascial lines are very well developed is this is quite a young, fit, healthy model. And this is what you see in a lot of nulliparous scanning, particularly in a female who's got very good kind of abdominal tone. When we look at a postnatal abdomen, these fascial lines tend to get a little bit distorted, almost a haphazard function. And then as we go to the midline, that right rectus is stopping, and that's where we get to the linea alba, which is that very fine, almost like a bridge. I like to think of it almost like a swordfish, nose pointing out, fin pointing out, and that bridge there. And we will look at that in a moment much closer. So just to recap really, initially scanning, putting lots of gel on, finding out where the marker is, it should match where it is on the screen, trying to work out what we should be looking at underneath. Does that match what we're looking at? And then starting to change the parameters when the probe is in place. And the sequence we did is we looked at depth, gain, TGC, and then we went up to these parameters here. Now I'm just going to get the model to hold the probe again. And then the one thing that we haven't talked about is freezing. So that image is now frozen. So if we were to move I've now got the probe, kind of nothing is happening. And then if I were to put the probe back on and I'm scanning, just keep your knees bent up. If I were to keep the probe, when we keep scanning, nothing will happen because I need to unfreeze. So I've now unfrozen. And sometimes that'll happen. You'll freeze an image. Let's freeze again. Image is frozen. And you're thinking, well, I'm scanning. So I'm scanning again. But I'm not seeing anything on the screen. And that's because that image is frozen. And it's good practice really is to freeze the image, especially when you're talking to the patient, when you're discussing things with them, so that they're getting less ultrasound input, so they're getting less exposure. Okay, I think we'll take a rest for a minute.